of course, I'm not sure you know. But about the sacrum, this morning I explained for you that at the first consists of 5 single bones, 5 single vertebrae. These 5 single vertebrae that belong to the sacrum fuse to each other and make one bone, one large and triangle bone. This large and triangle bone is visible here. Has 2 surfaces. Dorsal surface is visible here. In dorsal surface, you are going to look at 4 pairs of the foramen. 4 pairs of the foramen. Posteriorly, please notice, if you look at posterior to the sacrum, you will be able to find the superior articular process of the first sacral bone. You are able to find the superior articular process of the first sacral bone. What do you think? This superior articular process are going to be articulate with which articular process?
Lumbar.
Which lumbar?
5.
Lumbar 5.
Which lumbar bone? What? With which of the articular process? Superiorly or inferiorly?
Inferior.
No, because these 5 sacral bones fuse to each other, the spinous process of these 5 sacral bones fuse to each other and make a median longitudinal median sacral crest. So here you are able to find a median sacral crest. This median sacral crest is going to be formed by fusion of which structures? Spinous process that belong to the sacral bone, make a median sacral crest. About the 5th sacral bone, about the 5th sacral vertebra, the lamina disappear. So here, exactly inferior to median sacral crest, you are able to find a hiatus. A hiatus. This hiatus is a large notch. This hiatus is a large foramen that here you can find the inferior opening of the vertebral channel, the vertebral column. The vertebral channel inferiorly is going to be aimed to sacral hiatus. It is the sacrum and here is this hiatus we call sacral hiatus. Here you are going to be able to find the inferior opening of the vertebral channel, vertebral column. Means the spinal nerve, inferior spinal nerve are coming into the sacral channel. Sacral channel are here. And inferiorly, some of these spinal nerve are going to leave the vertebral channel through the sacral hiatus. Please notice here in this dorsal surface, you are able in each side to find another crest we call medial sacral crest. What was the name of this? Median. What's the name of this crest? Medial sacral crest. These medial sacral crests are going to be found medial to this sacral foramen here, both sides. We have K. We call medial sacral crest. What do you think? Which part of these 5 sacral vertebrae fuse to each other, join to each other, and make the medial sacral crest? Superior and inferior articular process. Superior and inferior articular process that belong to these 5 sacral bones form the medial sacral crest. What about the another crest? Come lateral to this foramen. You are able to find lateral sacral crest. To be able to get in your mind, remember the dorsal surface of my hand. It is the median sacral crest, medial sacral crest, and lateral sacral crest. The median sacral crest is going to be formed by fusion of the spinous process that belong to these 5 sacral vertebrae. The medial sacral crests are going to be formed by fusion of the superior and inferior articular process. What about the lateral sacral crests? Transverse process are going to be fused to each other and make the lateral sacral crest. So to be able to distinguish the medial and lateral, at the first find this foramen. Medial to this foramen you can find the medial sacral crest. Lateral to this foramen in each side you are able to find the lateral sacral crest. And here we have the median sacral crest. The median sacral crest, inferiorly, we can find the sacral hiatus. Why the sacral hiatus is going to be found here? Because of the disappear of the lamina that belong to the last sacral vertebra. The lamina of the last sacral vertebra disappear and make for us the sacral hiatus. The sacral hiatus is inferior opening of the vertebral channel. It was one of the questions, not exactly for the last semester, before the last semester. Which of the following item is going to show you the inferior opening of the vertebral channel? You should remember the sacral hiatus. Now, how many spinal nerves we have in our body? 31 pairs. About the sacral, how many sacral nerves we have? 5 pairs. So the S1, the dorsal fiber are coming out here. S2, S3, S4, S5, and the last spinal nerve are coming out from the sacral hiatus. So this hiatus is a place for coming out. Which of the spinal nerve? The
5 and 6.
Sacral nerve and the last spinal nerve we call coccygeal nerve. They are leaving the vertebral channel through these hiatus. If you notice here, this boundary of the sacral hiatus we can call the horn or corn of the sacrum. Horn or corn of the sacrum. They are going to remember you the inferior articular process of the S5. They are going to remember you the inferior articular process of S5. So the dorsal surface of the sacrum, you are able to find 5th sacral crest. Median sacral crest inferiorly make a hiatus. What's the name of this hiatus? Sacral hiatus. What's the name of this boundary? Sacral horn or sacral corn. And here we have the medial sacral crest. Here we have the opening. And here we have the lateral sacral crest. Yes? Sometimes it is possible in some of the patients, sometimes it is possible that you find the last lumbar vertebra fused to the first sacral vertebra. So what happened? How many sacral bones you can find in this patient?
5.
5 normally we have.
4, I mean 4.
3, 8.
Can you repeat what you said?
Look to me. The last lumbar vertebra fused to the first sacral vertebra. 6. How many lumbar vertebra in this patient we have? 4. Normally we have 5 lumbar vertebra. One of them coming and fused with the first sacral vertebra. So sacrum consists of 6 and the lumbar consists of 4. We call sacralization. Sacralization. You can find in your book. Sacralization or sacralization. Sacralization or sacralization. Sacralization or sacralization. Now, sometimes it is possible the first sacral vertebra completely or only in one side, never joined to the second sacral vertebra. What happened? The sacrum consists of, in this patient, from 4 segments, and the lumbar vertebra consists of 6 lumbar vertebra. This form we call lumbarization. Okay? Sacralization, lumbarization. If you come to the department of the Tehran University, the sacralization bone we have in the museum. Okay? Now, how many foramen in this picture normally we have in dorsal view?
8.
4 pairs. Okay? Now, in sacralization, how many foramen we can find? Yes. Sacralization means the sacrum consists of 6. So, because the L5 joint fused to the S1, another foramen is going to be formed superior. We can find 6 dorsal sacral vertebra. Now I notice, please pay attention inferiorly to the apex of the sacrum. The apex of the sacrum. Apex of the sacrum is going to make joint with the first coccygeal bone. What's the name of this joint? Sacrococcygeal joint. Use the name of each of them. Sacrococcygeal joint. Sacrum coccyx. This joint we call sacrococcygeal joint. Here, between the L5 and the S1, lumbosacral joint. Lumbosacral joint is a joint between which bone?
Between the lumbar and the S1.
Sacrococcygeal joint. It is a joint between the
S5 and coccyx.
the coccygeal bone. About the coccyx. Coccyx normally consists of 4 single and separate bones. These 4 bones fuse to each other and make one triangle and a small bone that we call the coccyx. The coccyx never has vertebral arch. So, in the coccyx, you are not able to find vertebral foramen because they never has vertebral arch. So the inferior end of the vertebral channel will be sacral hiatus. In the coccyx, we never have vertebral channel. We never have vertebral foramen. So the inferior end of the vertebral channel will be sacral hiatus. The first coccygeal bone is large, but the another one are going to decrease in size. Okay? Now, because 4 segments fuse to each other, we are able to show you 3 transverse lines. These 3 transverse lines are going to remember you that the coccyx normally, commonly, is going to be formed through 4 segments. How many? If I rotate the picture, what do you think? How many horizontal or transverse line I will be able to show you in the sacrum? 4. Look at here. Anteriorly, you are going to look at the sacrum. Anteriorly, you are going to look at the coccyx. Anterior view of the sacrum is concave. In anterior view, I am not able to show you the crest. It is smooth. In anterior view, again, I am able to show you 4 pairs of the sacral foramen. And because at the first, the sacrum consists of 5 segments, when they fuse, I will be able to show you 4 horizontal lines. These 4 horizontal lines are going to remember you that at the first consists of 5 small segments. Look at to the first sacral bone. It is the largest segment between the another segment bone of the sacrum. The first bone, if you look at to the body, in the first bone, if you look at to the body, here is the body. It is superior and anterior border of the body of S1. Do you agree?
Yes.
Yep.
Superior and anterior part of the body of S1. This superior and anterior body of the S1 project anteriorly and make a spatial part that we call promontory. We call promontorium of sacrum. This promontory is a landmark in midwifery. When the specialist, gynecologist, or the midwifery is going to measure the size, the shape, the size, the diameter of the pelvic bone to guess that this delivery is going to be appear and happen through the vaginal channel, or you should do the cesarean or another way, or do the surgery. This is a landmark. When the midwifery or the gynecologist put 2 fingers inside of the vaginal canal, they are able to feel the promontory. When they feel the promontory is here, belonging to the S1. Which part of the S1? Anterior and superior part of the body of the S1 project anteriorly, and it is a landmark, and we call the promontory. So it is a landmark. Here, each side of the body, you are able to look at a part that we call the ala of the sacrum. We call the ala of the sacrum. It is lateral part of the S1. We can call ala of the sacrum. The ala or lateral part of the sacrum is going in this picture to show you that belong to the S1. Now, another picture, if I change from lateral view, look at the sacrum. In laterally, sacrum is going to articulate with the hip bone, with the coxa, hip bone, pelvic bone. Do you know? Do you remember the hip bone? Hip bone, we have hair bone of the hip bone. In each side, the hip bone are going to articulate with the sacrum. If I rotate this picture, I will be able to show you lateral view of this picture. In lateral view, you are able to find an auricular surface, a facet articular surface. This articular surface is auricular shape. We call auricular surface. This auricular surface that belongs to the sacrum, it is going to be joined, to make joint with the auricular surface of the pelvic bone, hip bone. Now, look at the coccyx. The first bone in the coccyx group develop, but the other are going to decrease. The superior articular process of the first coccygeal bone we can call coccygeal horn or coccygeal horn. Now, I come back to this picture. Look at here. What's the name of this part? Sacral horn or sacral horn. They are going to be formed by which part of the spine?
The inferior part.
Articular process. Here, you are going to look at two coccygeal horn or coccygeal horn. They are going to be formed by the superior articular process of the first coccygeal bone. Okay? or first coccygeal vertebra. Now, here, what happened? You know, I explained for you. What happened here? What happened here?
L5.
Subluxation. If you notice, subluxation here is completely the L5 joint fused to the S1. So fifth anterior sacral foramen I am able to show you. Here, only in one side we have, not two sides, one side. So we have here variation.
Can we say about that disorders or it's normal things?
No, it is going to make problem. Normally make problem. What is this? In your book you find in Gray's Anatomy for Students, we call a spondylolisthesis. A spondylolisthesis. What happened that a spondylolisthesis appear? When the superior articular process and inferior articular process are going to make joint with each other here, sometimes something happens here and this joint, this zygoapophyseal joint have problem. So between the body and the superior articular process slide anteriorly and another part of the bone remain posteriorly, such as this picture. Normally, it is possible it appear between L5 and S1. Means the posterior part of the vertebral arch remain posteriorly, and here you have a dislocation or you have a fracture. So the anterior part slide anteriorly. Look at here, the name of this part we call promontorium. This spondylolisthesis can make problem for the diameter of the pelvic cavity because the L5 is coming anteriorly and make smaller the opening of the pelvic cavity. Here again you are going to look at the anterior and posterior longitudinal ligament, also the osteoprose. Have you ever heard the osteoprose? Osteoprose. What is the osteoprose? Who is ready to explain the osteoprose?
Is it when the neural tube fails to close during fetal?
No, it is a spina bifida.
Deformity because of vitamin deficiency.
As osteoprose, with the age is going to appear. For the woman, it is going to decrease of the the decrease of the concentration of the bones. Okay, so the bone become weak. With the age, it is going to increase. In the lady, it is going to appear 10 years sooner than the man. Osteoprose means the bones are going to get weak. So the structure of the bone, the volume of the bone is going to decrease. The concentration of the bone are going to decrease. So with a trauma, with a, for example, in the old man or old woman, it is possible when they threw down, it is possible they have broken bone because of osteoporosis. So with the genetic is important, the nutrition is important, the activity, exercise is important. If you do activity and have exercise, later the osteoporosis is going to appear for our bone. So the exercise such as the swimming is very good and useful to decrease and prevent the osteoporosis. Another congenital disease is visible in this picture. It is a spina bifida. What do you think about spina bifida?
For children,
To
babies.
explain?
When the neural tube in fetal development doesn't close properly.
Yes. You know, I explained for you that a spinal cord is going to be found inside of the vertebral canal. Yes? The skull is going to protect the brain. What about the spinal cord?
Right by the
The
vertebra.
vertebral column is going to protect from the spinal cord. Now, look at here. This morning I explained for you that here is the body and here is the vertebral arm. I explained for you about the superior articular process and here is the spinous process. Sometimes during the fetal period is so important, really important, because at the first we are a cell, this cell is going to develop and after 9 months everything is going to completely develop. If any problem, any factor may prevent the development of some part of the body in the fetal period, it is considered the congenital problem appear with the baby. Now it is possible when the two lamina are going to join each other to make a spinous process for one vertebra or for some adjacent vertebra, these two lamina never join to each other, fuse each other. So here you have the spinal cord. In this picture, in this patient, the spinal cord posteriorly is not going to protect by the bone. Now here, it is a vertebral channel. Inside of the vertebral channel, you have the spinal cord and the spinal nerve. Here, the posterior part of this vertebra never are going to be formed. So, loose connective tissue is going to support the content of the vertebral channel. We call a spinal bifida. It is a kind of a spinal bifida that we call a spinal bifida occulta. A spinal bifida occulta. Normally, in this baby, after the delivery, in the posterior midline, here it is possible you find the top of the head. You find some hair in the skin here. So you should distinguish, you can examine and find that here is the spinal bifida occulta. But sometimes the baby after the birth has a bulge posterior in the midline. What happened here? It is the same. Only the meninge and the CSF is coming up and make a bulge posteriorly in the midline. We call the meningocele. We call meningocele. Sometimes these spinal nerves also are coming inside of this bulge. We call meningomyelocele. We call meningomyelocele. Now here, it is, look at here, the baby after the delivery. CSF, yes, the birth is full of CSF. Now look at here, it is a schematic picture. What it is going to remember you, but in the posterior, in the midline, it is possible, is a spinal bifida acne. Okay? In all length of the vertebral column, it is possible it appears, not only in the lumbar region. Now, this position, this picture is going to remember you if you want to do the LP or lumbar puncture, which position the patient should have to help to you. It is the embryonic position. Embryonic position is such as this, okay? The patient lie laterally, for example, it is one of the position, on the bed and flex the foot and the hand, the tummy, so the distance between the spinous process increase. You find the iliac crest, put the needle parallel to iliac crest, you will be able to access to the vertebral channel. The inferior end of the spinal cord in adult is at the level of L2. So here it is safe. You are able to give or get a sample of CSF. But another thing that it is important you should know, because in the baby, the age of your patient is important. In adult, yes, but it is here. What you should know, in the baby, the vertebral column is going to develop, and the developing of the, or growing of the vertebral column is not complete. So the inferior end of the spinal cord in the baby is inferior. It is at the level of L3. In adult, it is at the level of L2. In the baby, it is at the level of L3 because it is going to, the growing is not going to be complete. So you should be careful about the baby. When you want to do the LP, you should be able, the tip of the needle never make problem for the spinal cord. Now here, one of your students this morning asked about the intervertebral disc. Look at the intervertebral disc. It is a schematic picture. About the intervertebral disc, please remember, intervertebral disc consists of two parts. Intervertebral disc consists of two parts. In the central part, you have nucleus pulposus. In the central part, you have nucleus pulposus. It is gelatinous. And in the peripheral part, you are able to find some circle lymphatic layer of the collagen, such as this. All of them are here. If you imagine, here is anterior and here is posterior. Anteriorly, it is thicker than posterior. And in the central part, you have nucleus pulposus. So here we have nucleus pulposus, and peripherally we have annulus fibrosus, cellular. Annulus fibrosus. Here, peripherally we have annulus fibrosus, and centrally we have a gelatinous liquid. What's the name of this part? Nucleus pulposus. Which part of the peripheral layer is narrower, thinner? Anterior or posterior? Posterior. No, it is possible sometimes. Something happens. For example, posteriorly and laterally, here you have a problem. This part disappears, or you have a fracture, such as the tube of the toothpaste. The content of this toothpaste is coming out here. So, the nearest nerve that it is passing here, with this bulging, is going to compress, and the patient is going to feel the pain at the range of his neck. We call herniation of the intervertebral disc. What is the hernia? The umbilical hernia.
It's when
Yes,
an organ leaves its connective tissue that binds it.
Organ leave the anatomical position. Normally it is possible and here around the umbilicus. You have a bulging here. Okay? Now it is possible in the intervertebral disc because the peripherally we have annulus fibrosus and centrally we have nucleus pulposus. We know anteriorly the annulus fibrosus is thicker than the posteriorly. And in posteriorly of the intervertebral disc, here we have posterior longitudinal ligament. We have posterior longitudinal ligament. This posterior longitudinal ligament is going to protect, to support posteriorly centrally. But this posterior longitudinal ligament is not going to be found laterally. So normally the herniation is going to appear intervertebral disc posteriorly and is laterally, left side or left side. It's possible happen here. Okay, such as a tube of the toothpaste. When you press, all of the content are coming out. Thank you. So posteriorly you have here posterior longitudinal ligament. This posterior longitudinal ligament in the posteriorly and in the central part is going to support. But laterally we never find the posterior longitudinal ligament, so it is possible the herniation appears retrolaterally. Here, look at to the thickness of the anteriorly and compare to the thickness of the posterior. Now here, we are going to look at to one of the intervertebral discs. And look at here, it is going to show you the spinal nerve. This spinal nerve is going to leave the vertebral channel through the intervertebral foramen here. If the herniation appears here, this nerve is healthy because never compressed. But this nerve, it is possible compressed with the herniation of this intervertebral disc. Now here, you remember this morning I explained for you the scoliosis. What happened to the scoliosis?
The spine moved to one side.
Because the herniation of intervertebral disc is going to appear this side. So this gelatinous nucleus pulposus is going to compress this nerve. This patient, to be able to decrease the pain, is going to curve to the opposite side, curve to this side, to decrease the compression of this nerve. So with the time it is possible the scoliosis appear. In this picture, when we remove the lamina, sometimes after the surgery, when you remove the lamina, the pain is going to decrease because the compression of the spinal nerve is going to decrease. Sometimes this approach is going to be revoked. And what is this? In your book, in Gray's Anatomy, you can find. It's going to show you that what is the vertebroplasty. Sometimes a liquid that is going to be formed by the semen. We can pass a needle through the pedicle, access to the body, and here, look at here, you have a fracture, you have an increase of the height. When you inject this semen or bony liquid to the body of this vertebra, you are going to help to increase the power of this bone. Now another bone that participates in the thorax, one of them is sternum. Sternum is easy. Which kind of the bone the sternum is?
Flat.
Flat. Which part of the body the sternum is visible? Midline?
Anterior.
Midline and head. The sternum consists of three parts. Superiorly we call manoberio. Superiorly we call manoberio. In the middle we call body. And inferiorly we call xiphoid process. You know the xiphoid process at the first is cartilaginous. With the age it is going to change to the bone. So how many joints I am able to show you in the sternum?
3.
2. This joint is important. It is a landmark between the manoberio and the body. We call sternal angle. This joint is important. We call sternal angle. You have here sternal angle? No. We call sternal angle. Sternal angle. So sternal angle is between which part of the sternum? A little, the sternal angle convex anterior. It is a landmark in your patient. It is easy to find the sternal angle. This afternoon when you go to the dormitory, stand in front of the mirror and find the sternal angle in your body because it is a landmark and it is important landmark. Then you find the sternal angle if you go laterally, which of the costal cartilage is visible?
First, it's called.
Second?
Second. The first costal cartilage is difficult for you because the clavicle is here. So it is not easy to find the first costal cartilage, but the second costal cartilage has a landmark. When you find the sternal angle, you go laterally, you are able to find the second costal cartilage. When you find the second costal cartilage, if you put another finger on the another rib, you are able to count all of the ribs. The second, third, fourth, fifth. But look at here, we have 12 pairs of the ribs. The first rib, the second rib. Between the first rib and the second rib, we have the first intercostal space. Between the second and the third rib, we have the second costal space. So all of the costal space are going to be found inferior to the number of the same costa. Here, what's the name of this costa? The first costa intercostal space is here. What's the name of this costa? The second costa intercostal space is located. Now, we have 12 pairs of the rib costa. The first seven anteriorly, the costal cartilage directly, separately, are going to articulate with the sternum. The first 7 costa we call true rib. First 7 costa we call true rib. What about the another rib? We can look to the picture. The 10th costal cartilage go up, make joint with the 9 costal cartilage. The 9 costal cartilage go up, make joint
With the 8.
with the 8 costal cartilage. The 8 costal cartilage go up, make joint with the 7 costal cartilage. So the rest of the costa inferiorly we call false ribs. True rib are the first 7 ribs, and another one we call false rib. And you should know the 12 and 11 rib, 11 and 12 rib, we can call free or floating rib. So true rib, false rib, free or floating rib, you should know. All of the rib anteriorly are going to be continued by the costal cartilage. About the 11 and 12, these costal cartilage never make joint with the sternum. About the first 7, they join directly, and about the 10th, 9, 8, they are going to join to the sternum through the 7 costal cartilage. This costal cartilage, this red color, in left and right side, in your body and in your patient is visible, is palpable, is important for you. We call the costal margin. So costal margin is going to be formed